Welcome, everyone, to the 2022 Virtual Compassion in Action Healthcare Conference. I'm Kathy Scopin, a Member Experience Advisor at the Schwartz Center for Compassionate Healthcare. Thank you for joining us for this panel discussion, Supporting Resilience and Social Justice During a Pandemic. Please join me in welcoming our presenters. Dr. Renee McLeod-Sorgen is the Vice Dean, Chair and Professor at Hofstra Northwell School of Nursing and Physician Assistant Studies. Dr. McLeod-Sorgen will act as our moderator today. Joining Dr. McLeod-Sorgen is Dr. Nicholas Mercado, who is a medical ethicist at Northwell Health and assistant professor in the Department of Medicine at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. We are so happy to have you with us today, and we really are looking forward to hearing about your work. So I'll pass it off to you, Dr. McLeod-Sorgen.
Thank you, Kathy. I so appreciate having us here. And we're going to present some work that was done during Northwell Health and take you back to a little bit of a time that we still really haven't gotten over from, but through the COVID pandemic. So we'd like to talk about resilience and social justice. And with that, myself and Dr. Mercado will get started. So we have a third colleague, Dr. Walter Markowitz, who helped inform this research. He was also the assistant professor at Hofstra School of Health Professions and the director of strategic planning, retired from Northwell Health. Unfortunately, he could not be with us today, but Nicholas and I will speak to the panel and his interests. So we'll get you started on today's agenda. We'd like to introduce some innovative initiatives and strategies that really promote workforce well-being, reduce psychological distress, and foster collaborative care among clinicians. We hope that by the end of this, we can motivate and empower you with the lessons that we learned from COVID-19 regarding crisis standards of care. And of course, promote resilience and collaboration using best practices and tools and effective ethical strategies to address burnout. So no talk would be remiss if we didn't thank our colleagues who, of course, during this period of time, worked on the front lines and kept hospitals and care facilities afloat. We want to thank you and show just a little 90-second video of what it looked like for us in the early surge of the pandemic in Northwell Health for nurses and other colleagues.
Say, smile. No smile.
So I press on the video.
He's away. Hold on.
Not using my microphone. Hang on.
Yes.
We'll be heading into my shift.
We're gonna do glasses for a second so I can make sure I'm not blocking the camera. This is what we need so we can stay awake when we go to work, right? Otherwise we're tired.
Gonna shut everything off and go to bed.
A lot of people got sick. A lot of people are doing worse.
Trying to calm the knot in my stomach right now.
All of this is so scary because it's not even bad yet. Like, it hasn't started yet.
Oh, no, go back there. Go, can't touch mommy right now. It's a really difficult situation. I really think that people need to see what we're going through.
Once you see what we're seeing and what we're experiencing, it's hard to not feel anxious or upset because the cost of human life is too great.
We'll see how this goes.
So I know for many of us that site was all too familiar for us at Northwell Health. I want to tell you a little bit about our organization. Northwell Health in New York State is one of the largest providers of healthcare services. We're not merely a hospital system, but we stretch through ambulatory care services, ambulatory regional efforts. We're 23 hospitals with 3 long-term care facilities, and we're home to the Feinstein Institute for Medical Research, as well as the Zucker School of Medicine and the Hofstra-Northwell School of Nursing and PA Studies. This will become very important as we talk about resilience and we talk about creating interprofessional teams. You may know us because, of course, during the midst of the pandemic, you got to know our nurses that were on the front line that sang every day to their patients. And of course, we're on America's Got Talent. We're home to more than 17,000 nurses, 1,200 nurse practitioners, and the governor at the time really appealed to our CEO, Mr. Michael Dowling, and several of our nurses volunteered to work in Houston and in other areas in response to the appeal for healthcare workers. So the background really to our topic and what we want to discuss is that Hofstra University and Northwell Health have a unique academic practice partnership where they share governance in operating and establishing both the nursing school, both the medical school, and of course the efforts in Feinstein. So even before COVID, the IOM report of 2010 told us that we really needed to improve patient care and safety across all educational systems, and particularly among nursing. Myself as the Vice Dean of the School of Nursing, and Dr. Mercado, being in the School of Health Professions, collaborated not only as ethicists, but across the university, both of us having appointments in the medical school and appointments in the other areas of the university, as I've already described. The communities that we serve are also very vulnerable. The 5 communities that sit around the 5 miles of Hofstra saw the most disadvantaged areas by social determinants of health. And you can see here that Northwell Health has these hospital systems that sit uniquely between Queens and Nassau and Manhattan. Moving further, looking at the disadvantagement of our high school students, you can see that several of these areas, more than 73%, 66% in areas of Manhattan, such as Harlem, Staten Island, South Central Nassau, Huntington, and Southern Western, have really economically disadvantaged high school students. These are 11 communities of color that sit right at the epicenter of where COVID was affected and where our patients were. We saw in the next slide, you'll see more than 300,000 patients that were unique patient visits just in the first surge. So most of what Dr. Mercado and I are going to be talking about is talking about the 30 days. Bringing you back to those 30 days in the next slide, you'll see that we thought we were dealing with unprecedented flu cases between January and February. By March 1st, we had our first positive case of COVID-19, but we thought that there was no reason for undue anxiety. Within 2 weeks, we were closing many of our hospitals. Within 2 weeks, we were talking about an invisible, ruthless killer. We were talking about a deadly virus, and we were talking about the burden of that emotional struggle for clinicians, both facing their own professional duty to their patients, but their personal fear for themselves. On the next slide, you'll see this meteoric rise over these 30 days. I can tell you, as also being the director of the Division of Medical Ethics, during this period of time between March 30th and May 4th, we were 24/7, where neither Dr. Mercado or myself sat without our phones. We slept with our phones. We were 24/7 responding to ethical dilemmas in clinical cases. In addition, Every clinician that could take care of patients also took care of patients. Myself being an acute and family and palliative nurse practitioner, there were many days that I were in the ICU, also taking care of patients during this period of time. There was a devastating toll that we know from the CDC, not only by cases and hospitalizations, but by death related to race and ethnicity. If you recall the prior slides that I showed you in the introduction, these 11 communities of color that sat in the epicenter of what we covered was no different. And by zip code, there was a devastating toll of death by race and ethnicity. So taking you back to where Dr. Mercado and I really became involved in supporting resilience, had to do, if you bring yourself back into New York on March 24th, this Forbes article, how were we going to allocate the scarce resources that we had? And so during this period of time, the Empire State Bioethics Consultation was created. And that was created with the help of Dr. Louis Voigt out of Memorial Sloan Kettering, who brought together 45 ethicists from across the country that led every program director in the upstate and downstate of New York. And when in each of our hospitals, we were trying to answer this question. On the following slide, you will see the reference to the article, the mixed method article that we published that looked at how we had this ethical approach to the moral distress, because early on we thought we were going to run out of ventilators. What was very true was we were running out of people, the capital, and ventilator allocation had a much easier solution than dealing with the moral distress of overworked and understaffed clinicians, who was, as you remember from that 90-second video, had families, had homes, had loved ones that were also facing devastating tolls. So our job, Dr. Mercado and I, was to transition from what we thought was going to be the problem with allocating ventilators and life-sustaining treatment to rapidly addressing the clinical distress that was going on among these clinicians that were working 24/7. So as I turn over to the next slide, just to tell you about some of the themes that came out of this research, that there was a lack of preparation for handling the demands of the pandemic. We didn't expect this. We thought we were dealing with flu. And what Dr. Mercado and I frequently heard on these calls were distressed clinicians. And not only were the clinicians distressed, but the people who were prepared, palliativists and ethicists, to deal with this moral distress equally had distress. The third theme was that there was tremendous support from peers, from members of what we created, a hospital clinical review team that gave support. And the number one and number two themes was how hellish and profound these challenges were, and that there were tremendous tension that occurred not only from the hospital clinical review teams, but the clinicians, because there was a constant need, or the perception of the need, to make life and death decisions without the normal, usual social supports of the community and of the family members. And so even prior to this research, we knew on the next slide that there were relatively important stressors, not only for physicians, but for advanced care providers. Of course, being an advanced practice provider and a nurse myself, it really struck me even before COVID This article comes from 2018, that when it comes to well-being, clinicians have different views about which stressors are the most important stressors. In the past, inadequate staffing, patient death and suffering were not the big parts of the pie. The past big parts of the pie were the functions of the care teams, were the organizational values, were the internal perfectionism and role ambiguity. Those were the stressors that we were day-to-day prepared for, but not for the stressors that we were going through now. The risk of the meaning of what we were doing, the moral distress, patient death and suffering, inadequate staffing, COVID brought these to the front. And that also is equally going to be important as I set you up for our practice challenge and the first panel that I will turn over to Dr. Mercado. So here's the practice partnership challenge. How do we support the health, the welfare, and resilience of the community, staff, and patients? We were lucky to be led by Mr. Dowling and to have Mr. Dowling and all of the administrators of Northwell Health, no matter what department they were in, to really talk about that. That was the challenge that we had to really look at. Health of the community, health of the staff, health of our patients. And this quote comes from Mr. Dowling in his book that he wrote about leading through the pandemic, that the pandemic stands without doubt the most frightening, overwhelming experience and the most humbling, because not only were we stunned by the power of the virus, but we were stunned by the disease it caused. And the reason we're bringing this to you now, almost 2 years later, is to think about the lasting impact that this will also have on all of us. So with that, Nick, and looking at the first kind of panel discussions that we want to talk about, if you can speak to, what experience do you think Northwell had, or even what experience do you think that you had to be prepared for this challenge?
With a fascinating question like that, I think part of what prepared me was to kind of inflate your ego, Dr. McLeod, was your teachings. When it comes to the challenges in medical ethics, day to day, we would deal with situations involving treatment plans, refusal, end-of-life care, challenges between stakeholders involved in a patient's case. And that was usually an individual patient. And one of the things we had to kind of shift our focus on was this individualized way of treating patients to a more global, utilitarian, justice-based framework for how do we not only, as you mentioned, allocate ventilators, which was basically a proxy for all resources that we had at our disposal, including medications, including personal protective equipment, the staff and clinician time and how much time they can dedicate to an individual patient, but also how we kind of go from that mindset of an individualized way of doing healthcare to that more global experience. And people are not taught how to do that. We don't teach our medical students how to do that. We don't teach our nursing students or physician assistant students. We teach them this patient care model. But what happens when you go from that individual patient care model to a public health crisis to this magnitude? How do we learn to do that triage? And I found that it was very difficult for our learners, our non-seasoned clinicians, as well as our very seasoned clinicians. Because as you described, having my phone next to me fully charged all through the night having seasoned clinicians, physicians, leaders that I worked with have their voice quake on the other end of the phone as they were describing this situation. It was quite humbling, if I were to say it. And so if I were to look at it from myself as well, from a systems perspective, I think that Northwell saw the role of this multidisciplinary ethical team that you spearheaded and created the system ethics committee so that when, not if, but when something like this happens again, we would have something in place. And my only fear is that if history is of any real tell, that our memories are sometimes very short, and we sometimes go back to a way of doing things that will put our most disadvantaged in that vulnerable place again.
Yeah, I think that that's an excellent point that you bring. It's like, how do we move these lessons forward? And, I find that even with what you said, our memory was short. So in New York, we had gone through Hurricane Sandy, and Northwell Health had created an incident command system for the region. That was brought back out. But I think one of the other things is that really just remembering that academic practice partnerships don't exist only for academic purposes, that academic practice partnerships exist for clinical purposes. So the ability to shift from individual patient care to doing collaborative, comprehensive care to the community was also really interesting. So thank you for bringing that up, Dr. Mercado. So let's talk about how we operationalize this challenge. And you've already alluded to it. We created a 24/7 system ethics response triage team. The real issue is that triage quickly came out of it, as Dr. Mercado said. The idea was, could we have system improvements that would not only have, response, but effective surveillance? So in other words, support the frontline staff making the clinical decisions and try to create a place where all decision-making, all algorithms, all latest research could be in one place. But that also meant expanding from what we were doing in the hospitals to community partnerships, going into the long-term care units, the churches and the schools, to alleviate fear in the community and be transparent with the community. But also it meant expanding the workforce. Never ever before had this idea about full scope of practice. So you saw on the prior slide that advanced practice providers, that was one of our biggest stressors, is what was our scope of practice. And that meant beseeching the governor and the powers that be to expand scope of practice in New York State. Enhancing the availability of decision support tools meant rehauling all over our electronic health records so that at every clinician's disposal would be the decision tools for the most up-to-date best evidence, so that people could feel secure that they were delivering appropriate care. And then that also meant creating these interprofessional partnerships so that the academic arm, the clinical arm, and the research arm were not separate entities, but that they were sitting in one place, communicating in real time, working in real time together. So some of the other key activities had to do with, on our next slide, developing and strengthening excellence around what soon transformed as the year went on to the allocation of COVID vaccination, monoclonal antibodies, and surveillance testing. The academic arm, both at the School of Nursing and the School of Medicine and at Hofstra's Student Health Services, then had to come to train faculty. And faculty had then brought on a new word. Not only faculty in the academic arm, but also faculty in the clinical arm. And that also meant that we had to create new electronic workload schedules so that it allowed faculty to not only clinically practice, academically practice, and carve out time for research. And I'm also wondering, Dr. Mercado, because you yourself being along a tenure track faculty line, how this felt for you to now have tenure not just be on what you published, but also be on your clinical arm and your outreach as a public health person.
Yes, that's a great question. I think one of the things that our academic system, certainly not all institutions, but in many institutions, a lot of what is focused on is how do you get your name out there in terms of peer-reviewed publications? And sometimes it neglects the practice aspect of the field in which you're in. So as a public health professional, as a clinical bioethicist, I feel that what we have hopefully moved to is that there is more to being an academic than just what you write about. I think it's also about how you mentor learners, how you mentor your peers, and how you engage the community and help shape community standards of care so that once you are in a position such as this, which this will not be our only one, but when you're in a position that you start fostering that trust amongst community members sooner, rather than when we are already in such a highly stressful situation. So as an academic who does see patients, who does do research, who does do a lot of teaching and service, I feel that we have to somehow figure out a way to weigh these different aspects of our job responsibilities so that we do engage in community standards, that we do foster this trust amongst the community. And I hope that when our peers start to see our young academics who are looking to get into the field, as well as our seasoned academics who are looking to try and mentor these young academics, that we incorporate this feeling of trust and interprofessional practice where we can build up our young and where we can build up our engagement with the community. I would also want to add one more thing in that, the learners who were looking to get into healthcare, not necessarily the ones who have been in healthcare for a while and are advancing, but the learners who are looking to get into healthcare were quite concerned and scared, and having the opportunity to work with students at the pre-health professional line, you get to see what they are exposed to. You got to see how impactful you can be as a faculty member in trying to give them not only the knowledge, but also the exposure to how it's going to be like for them in the future. Some of them decided that they want that this experience, that the COVID-19 experience, doubled down on wanting to become a clinician, and then it actually sometimes it had the opposite effect. So I think that we play a very important role in shaping these students, but also trying to shape the minds of the community so that we can again do better and foster that trust sooner.
Dr. Mercado, I think that that's the perfect segue into the next few slides and what you're bringing out. Because in order for clinicians to become more seasoned, we do need the communities. And so the next few slides, we're going to show you a little bit about what this looked like in the 5 communities that were federally qualified health centers that sat within 5 miles of not only Hofstra University, but also Northwell Health. So one of the things that the communities in Long Island were very, very important in doing was also driving down viral infection rates. It was the relationships between the churches and the education individuals in the synagogues that helped us have these public health victories, because they actually were going out with testing supplies and encouraging people to come in. As an academic, and thinking about resilience. And as we move forward, this gave us the opportunity to really look on the next slide at social determinants of health. The social determinants of health during COVID, and also, we'd be remiss if we only made this about the infection pandemic. At the same time, we all know there was a social pandemic, George Floyd, and all of this was happening in that summer. The social determinants of what was going on with access to housing, particularly the highest rates were in housing that had multiple dwellers in small enclosed spaces, with access to food and healthy choices. Please forgive me. With access to food and healthy choices, as well as looking at economic state stability and education stability and social context. So at the time when we're going through this social and infectious disease pandemic, now we have public health coming more to the forefront, and we had to create this language. So on the next slide, our colleague was Dr. Markowitz, myself, and Dr. Mikado were very involved in trying to get participatory community engagement along with students to address the social determinants of health. And that was done a lot through surveillance, screening, and testing. So Dr. Mikado, if you could speak to just how Hofstra went about this and the partnership with Northwell Health and your thoughts.
Sure. One of the things that I was privileged to have during the academic year was to be a participant in this surveillance and screening process. We would invite all of our students, well, invite is a kind of a loose term, but we would invite our students to come and get tested at one of our bigger halls, one of the gymnasiums at the Hofstra University. So we had many different clinicians from physician assistants, nurse practitioners, myself included, to try and make sure that we knew how our community, our college community, as well as the surrounding community, was being impacted by this virus. And it included, again, the surveillance testing. It included analyzing, as you said, Dr. McLeod, the social determinants of health, whether or not our students were living on campus, did they have the opportunity to engage with the with what we deem to be the appropriate college life. And I found that it was very, very important to try and validate that what they are doing in an attempt to continue their education, even despite everything that has been going on, it was important to give them that commendation. And in terms of giving ourselves our time when we were still teaching, when we were still doing consultations, when we were still doing this stuff, to try and make it that we were engaging in the appropriate public health standards, that we were engaging and that we were monitoring the progress of how this virus was permeating our student body, as well as our employee body, our faculty and staff body. I think that we partnered, we became siblings in arms. I don't want to say brothers in arms because there's a whole gamut, but we became siblings in arms in this as we were all fighting this battle together.
I think that's an excellent point to really talk about, that this was no separation between the community and the clinicians, and having that community support is also one of the things that built resilience. As we move on, I think the two biggest concerns, and Dr. Mercado alluded to this, was the burnout for medical students. In fact, one of the things that we kept hearing, and this wasn't one particular profession, was that this was nothing that they ever expected to occur. And in particular, I'm thinking about some of our fellows that were in areas like urology or dermatology, that now we're seeing life and death play out was not an area of medicine or nursing they were used to. So I know that Dr. Mercado, you had specific techniques that you utilized during this 2-year period of time to really kind of address burnout for young learners, particularly medical students and nurses. So if you wanted to speak to that.
Sure. I feel that particularly when the pandemic first hit and our medical students who were on the floors completing their clerkships had to emergently be taken off those clerkships because they didn't want any quote unquote non-essential personnel in the floors when this was going on until we got a better handle on it, was particularly distressing for these students. So what one of the deans of the medical school, as well as one of the chairs of the academic departments, asked me to do was to develop a session, a simple 1-hour session that could be done with groups of medical students as they learned about the pandemic. We called it the life cycle of a pandemic. And while you could have used the pandemic, you could have used the HIV/AIDS pandemic, you could have used the Black Plague, you could have used any pandemic you wanted. It made obviously a lot of sense to focus on coronavirus. And so what we wanted to do was we wanted to have our students look at what is being broadcast, what is being turned out to the public about what is happening. And we would analyze it from a moral perspective and an ethical perspective as we started diving into how we were not only going to allocate our resources, how we were going to take care of our most vulnerable, how we were going to handle the situations in our prisons, how we were going to handle the situations in our nursing homes and other long-term care facilities, and give them an open, safe/brave space to expand on what they were feeling at the time. Was their education going to be impacted by this? Are they going to be worse clinicians because they were not able to complete their clerkships in the time frame that they were supposed to complete their clerkships? How were they conversing with their peers and colleagues at other medical schools or other health profession schools who were not as impacted by this and were still business as usual when it came to their education? How were we going to try and contend with those concerns? And I think what we ended up doing is we created multiple different departments in the medical school. We expanded our diversity, equity, and inclusion department to include issues involving social justice and social determinants of health. And we made it a point to try and include ethics and professionalism in more threads of the medical school curriculum. And I feel that over time, our students got the understanding that they were going to be not only effective clinicians, but they will say that I learned during this time. And I will have the opportunity to take what I have learned and hopefully bring a social justice aspect to my care of patients, a social determinant aspect to my care of patients. And I wanted to kind of briefly touch on what you talked about with respect to our residents who were already in training, our fellows who are already in training, having to go to a field or go to a unit to which they had absolutely no idea or couldn't remember what it was like doing that work. You know, our urology residents who are now in the medical ICU, our pediatricians that were now taking care of adults when they haven't had the opportunity to take care of adults since they were in medical school. And it was well worth the experience. I can mostly speak for myself. It was well worth the experience to try and alleviate some of that moral distress when I could, to try and address that issue of burnout, because we saw a lot of turnover and we saw a lot of people saying, you know, this is not for me. I did not, quote unquote, sign up for this.
Yes. And I also want to speak to is exactly as you also alluded to, that, you know, not only was this going on, but the social pandemic was going on. And so there were several clubs and several forums to address the diversity, equity, and inclusion put forth by the students themselves. So as, you know, you also kind of hinted on this as well, you know, that we had existing clinicians from all walks, and not only the clinicians, but people who touched or interfaced with patients in every way, who were losing loved ones in the community. So can you also speak to how we integrated behavioral health and the integration also of how you use tele-ethics or tele-resources to address moral distress?
Right. I think at the very beginning of the pandemic, we started to see the necessity of trying to touch more institutions. I'm speaking specifically regarding ethics, but in terms of, again, addressing the issues of moral distress for our clinicians, we saw a real benefit to being able to talk to them, not just over the phone and being just another voice on the end of the line, but for them to see our facial expressions, for them to see that we are listening to them, that we are giving them that space to express what they are feeling. And so when we talk about, integrating behavioral health, I consider moral wellness as part of that because, not being a psychiatrist or a counselor or a therapist, I can't really say that am I really well versed in the, behavioral techniques. But what I am trained in is to listen, to provide that space, to say, tell me about this experience and what do you want to take away from it? And our clinicians finally, I think, felt that that the stigma for having mental health concerns in their field was not as strong, and that it was understandable that they were feeling the way they were feeling because that we were in this position. And I can only say, as a proponent and an advocate for mental health, it really pains me to say that it took a pandemic to bring us there, to say, okay, you shouldn't be ashamed to say that you are having these behavioral health concerns, but we gave ourselves that opportunity to try and mitigate that stigma. And I hope that we will have the opportunity to do that more in the future.
Yes, and not only was that available in terms of, providing these codes done by the response teams, but those resources were made available to all employees that they could reach out and have psychiatry and behavioral health.
Right.
So I guess the other part from this is for us to give you an arching framework. You've heard some parts of the panels and how this occurred. You've heard the problem, but now let's pull in where did this come from? We didn't just pull this out of the sky. So the National Academy of Sciences actually had a conceptual model to address clinician burnout. And even before the pandemic of COVID, clinician burnout was an epidemic and is part of the quadruple aim to really look at clinician well-being, and the clinician-patient relationship sits at the heart of that well-being. So we looked at all of these factors, but some of the factors that were most important during COVID were these personal factors and skills and abilities. And what were the sense of what were healthcare responsibilities? So what we put into place on the next slide was really trying to think about evidence-based action that came from a Swenson article to talk from quality and safety from 2017, so way before COVID, to think about joy in practice. How did we build a social community? Particularly, how do you build a social community in a large health system that is more than just 23 hospitals and long-term facilities, but all of these other areas that are touched, even internationally and locally and nationally? So the idea was, could we strengthen individual resilience and individual wellness? So we've talked to you about the singing that the nurses did, or the fact that whenever a patient was discharged, we played George Harrison and the Beatles' Here Comes the Sun. We also tried to bring food, sustenance, nutrition, housing, so that people who had young children didn't necessarily have to go back to their home and expose their children and their family. But the other thing was to eliminate and mitigate structural and functional drivers of burnout. We began to design organizational systems so that at 3 checkpoints during the day and evening, everyone would come on to Microsoft Teams. In fact, Microsoft Teams became the way of communicating throughout, so that at any time during the day, we could just send messages or emojis to each other to lift each other up. But the other thing was to have individual wellness. We need to have a satisfactory social and psychological purpose. And yes, the purpose goes back to everyone knowing what the mission and the purpose was, which goes back to community, staff, and patient wellness. So from the point of view of ethics, we also needed to create virtual resilience. And so a lot of what Dr. Mercado and I have been talking about was how did we create an ethics triage team? Well, ethics is usually something that's not paid for. There are just not enough ethicists and not enough palliativists, and certainly not enough to have provided pandemic response to this large group. However, this goes back to the academic practice partnership. For 11 years prior to the pandemic, we had been training residents, training medical students, doing a certificate course, training social workers and chaplains. So we were able to pull together 118 people that had been trained in the 10 years preceding, and to create this idea of what were we going to do to have an algorithm. One of the things that came out of our research was that by having a rule actually gave support. By feeling that you were following a guideline actually gave support. So let's talk about some of the solutions. We've already alluded to telehealth and teleethics. So we had 18 emergency departments using telepsychiatry. This wasn't only a COVID-19 response. The allocation had to go out to all patients at a population health level, regardless of what your diagnosis was, which meant that we needed to create telecritical care because we had critical care areas that were staffed with people who were not used to doing telehealth. Another solution as we move forward was teamwork. You may recognize a colleague from LIJ Hospital System. This is Sandra Lindsay. Dr. Sandra Lindsay was the first person to receive the COVID vaccine. She participated in community vaccine programs. Overall, having her sponsorship and going out and having the community response during the initial period led to over 676,000 doses being given out, including 473,000 in the community, where all of the leaders of Northwell Health took different community responses and went out into the community. Another solution you've heard us talking about was having this idea of faculty practicing in the COVID-19 ICUs. Here's myself and Dr. Jennifer Laffey, who at the time was the Senior Vice President for Advanced Practice Providers working in one of our local ICUs. Not only did they staff ICUs, but we created influenza pods, dispensed influenza vaccinations, and then also, of course, COVID vaccinations and COVID testings. At the height of the pandemic, faculty alone had administered almost 5,000 vaccinations. And Dr. Mercado and myself were staffing surveillance and doing surveillance every day in all of our university sites so that we could keep the university open. But as we're beginning to close, one of the key things was to develop and strengthen operational writing. And this writing exercise, as we go through the last two slides and begin to turn things over to questions, is asking people simply, we had lavender everywhere. Write about one thing that you did today or this week that you're proud of. Write about the hardest thing you did. And if a family member or friend was in your position, being an essential healthcare worker, seeing what you're seeing, doing what you're doing, what would you say to them? And to have our clinicians write down and journal, and many of these journals have now turned into spoken word pieces or shared with our younger individuals. So in our last slide, before I turn this over to Kathy and open up to questions as we get to 10 minutes, is to go back to the quadruple aim and what we've learned even before COVID. And this is one of the techniques that we hope you get to. Stop and pause. Take a breath. Observe what you're feeling. And for everything with ethics and palliative care, is to proceed with awareness. And so some of our outcomes, just quickly, we integrated mental health and well-being support by creating a physician resource network, as well as an employee and family assistance program, so that this could be confidential. Secondly, you'll see Nick, you'll see myself and Michael Dowling. We went into the community, and with our local radio stations and our local TV stations, we advocated and supported about public engagement. We cannot feel fulfilled unless we're also fulfilling our duty in the public. And one of the most proud things that I'm proud of is that students who were in the midst of being in COVID and graduating took their public health coursework and actually brought it into the community. These two young ladies created their own not-for-profit called Let's Talk Health Ladies, where they give health information to teens and young women, because lots of resources were not available because we were completely invested in COVID and they wanted to help teens. And so our future implications are there will be disruptions caused by COVID. We have to be aware that there were education disruptions, work disruptions that hurt the Black and Brown and disenfranchised the most. And so what we hope your summary that you've gotten through this is, without having comprehensive community and stakeholder outreach, we cannot mitigate the effects of any pandemic. And so we have to make this learning environment not just a learning environment for students, but for us all. And with that, I want to share a rendition that sits in our hospital. And this is a presentation called The Frontline Warriors that were done by New York-based artists, Sergio Borelli and Angela China, that you were warriors, and we stood shoulder to shoulder, hand to hand, with the gloves to make a difference. And so, Kathy, we open it up. Dr. Mercado, and I to any questions.
I have to say that was breathtaking. I have to catch my breath. Just such wonderful information. And I just want to say that it's so important. I think that was said, when, not if, we experience another pandemic. I mean, you've given us such valuable information. There is a question that I'd like to read from Elizabeth Cantor. I heard a theme of engaging community organizations. Understanding there's a spectrum of such entities, is the idea to engage local practitioner schools like nursing, medical, respiratory therapy, paramedic, et cetera, food banks, religious organizations, et cetera, with the goal of providing reliable education? What were the objectives, of engaging community organizations?
I love that question. and yes to all and everything. But the most important thing that I want to say is by community participatory engagement was not what we wanted, but what they wanted. One of the things that, I didn't speak to a lot of what we did as a nursing school during this time, but as a nursing school, we launched a brand new undergraduate nursing program. We launched a new nurse anesthesia program that was the first and only in its country to be joined with the acute care NP program, because as nurse anesthetists were re-engaging, there was a limitation in their scope because many of them had never covered the ICU. And so what we did was we reached out to the community and found out what the community wanted. One of the things our local Uniondale community wanted was that they had a pipeline program with LPN programs, and they couldn't get their students into a 4-year program. Well, we partnered with them. Our faculty during COVID taught the courses to those students because they couldn't get clinical time. And now, since that, after COVID, we now have a pipeline program to get those students into school. So I love this question because, true public health is not what did we want? It was what did every person that we engage want? And out of this became a community and public health office in Northwell that continues to do this work and now has been funded and now is staffed by only over 15 different public health workers.
That's incredible. So, I go back to the thought of, how do we get this message out to everyone that this is something, obviously you are sitting in such a great place. If, again, we experience something like this, and obviously the pandemic is not over, but if something else comes along, how do we get the word out that this is something we need to be prepared for, to other organizations, to the government? How can we get this out?
Well, first, I think Dr. Mercado and I thank the Schwartz Center for even letting us disseminate and talk about our experience. Second is something that I alluded to very briefly, but pandemic preparedness, or the duty to prepare, this was not new. We believed that there was going to be an overwhelming epidemic of flu. The problem was COVID didn't prepare like flu did. So one of the things that was lasting for us in New York, upstate and downstate, was that Empire Bioethics State Consortium, where we all got together regardless of who was paying the paycheck, to share resources and to also share patients. I think one of the things that we've got to get out to each other and to the federal government is that there's no such thing as no resources for all. I won't preach, but we have Medicare that covers the elderly and the disabled, but we don't have universal health care to cover everyone else. What I'm really hoping that comes out of this pandemic is that we realize healthcare for all, and we cannot hoard. We have to share. Mm-hmm. And there has to be a mechanism of healthcare for everyone, that it didn't matter what zip code or what hospital system, that you could have still had the same resources. And that was not the case in COVID.
I would also add that our focus on how we do healthcare in the United States is inherently flawed, as we do not do a lot of work in addressing the socioeconomic determinants of health. We don't do a lot of work at building up infrastructure. We don't do a lot of work in trying to create, or at least make, housing affordable and accessible. The aspects that influence our health, the economic, the social, the environmental, that has a greater impact on our health than access to healthcare, we spend the least amount of money on. We spend the least amount of resources. We spend 2% of our gross domestic product towards healthcare on public health efforts and 98% on everything else. That has, again, the least amount of impact on our individual and community health. And I think if we shape that focus towards more of the socioeconomic determinants of health, more to trying to get people well instead of providing sick care like we normally do, we would have a greater benefit. And we would have the opportunity to engage with our community organizations to try and deliver that, because that's what their aim is to try and improve wellness.
I would also like to say, Kathy, and it's something you asked, what should we say to the government? I mean, we've been trying to move the palliative care lens and framework for more than 50 years. In terms of ethics, more than 25 years. And yet there is an NPI identifier for medical ethics, but it is not a billable event. And yet not every hospital and not every institution and not every long-term facility has palliative nurses or palliative physicians. Imagine if in our health systems, we didn't have a palliative approach. So I think we have to put our money where our mouth is. This is one area of nursing and medicine and social work that we all have in common is palliative and end-of-life care. We need to continue to fund research and resources there.
As a nurse, I agree. And I think that's a really wonderful note to end on. And again, I want to thank you so much. This is just a fabulous presentation. And we appreciate your time, and thank you for our audience also for attending. We'd also like to thank our national business members again for their year-round support of the Schwartz Center. This conference would not be possible without them. We're going to go ahead and take a 15-minute break, and then please refer to your attendee hub to select your next session. Thank you again, and enjoy the rest of your day.